Hello and welcome back to the Academy of Anaesthesia. In this second part of temperature monitoring, we will go over the physiology of thermoregulation, the definitions, and the pathophysiology of hypothermia, as well as the management strategies. If you haven't already seen part 1, pause the video and check it out so you can get a comprehensive understanding of the methods of temperature monitoring and the physics of heat loss. This video is more clinically focused and therefore will be useful for both the primary and the final FRCA. With that said, let's begin by describing thermoregulation. As with most feedback systems, you can divide the interplay of thermoregulation into sensors, integrators, and effectors. Heat and cold sensors are found peripherally in the skin and deep tissues, and centrally within the spinal cord and the brainstem. As you might remember from the pain pathways video, temperature and pain share the same pathways. Cold receptors are innervated by A delta fibers, and heat receptors are innervated by C fibers. Both of them send signals to the central integrator, the hypothalamus. An integrator is a processor which combines inputs to form an output. In thermoregulation, this role is taken by the hypothalamus. The signals from the temperature sensors are sent to the preoptic nucleus of the hypothalamus. This is the body's internal thermostat. The posterior hypothalamus maintains the core body temperature between 36.7 and 37.1 degrees Celsius. If the core body temperature signals sensed by the hypothalamus are outside this range, then it kicks in a range of effectors to normalize the difference in temperature. The effectors can be subdivided into neural, hormonal, and behavioral. Neural changes include vasoconstriction via the activity of alpha-1 receptors on blood vessels, shivering, piloerection, and a process called non-shivering thermogenesis. Non-shivering thermogenesis is where the body activates beta-3 receptors and breaks down adipose tissue to produce heat energy. This process has a much more important role in neonates than in adults. Hormonal changes that occur include an increase in circulating catecholamines and an increase in the production and release of thyroid hormones. Both of these act to increase the metabolic activity in the body to increase heat production. Finally, behavioral changes mediated by the frontal cortex will lead to things like putting more layers on, eating warm food, or perhaps drinking a warm cup of tea. On the flip side, if the body is too hot, the anterior part of the hypothalamus implements cooling mechanisms such as vasodilatation, sweating, and behaviours such as taking off layers and seeking shade. That's it for thermoregulation. Now let's switch gears and focus on the clinical aspects of hypothermia. Most definitions of hypothermia class it as a core body temperature below 35 degrees Celsius. It can be classified according to severity, where mild is between 35 and 32 degrees Celsius, moderate 32 and 28 degrees Celsius, and severe between 28 and 20 degrees Celsius. Profound hypothermia is classed as less than 20 degrees Celsius. You can have primary hypothermia, which is where an individual is exposed to environmental circumstances such as adverse weather. Secondary hypothermia occurs when a pathological process leads to a drop in core body temperature. The causes of secondary hypothermia can be subdivided into those patients that are losing heat too quickly, such as trauma or burns patients, those patients who cannot generate heat quick enough, such as patients with hypothyroidism, hypopituitarism, or hypoadrenalism, and those patients who have a problem with the central integrator, such as those with a stroke or intracranial hemorrhage. Moving on to the signs and symptoms of hypothermia, you can classify these into different systems, but as a general rule, each system has an increase in activity, also known as the compensation phase, and then a decrease in activity, eventually completely halting, aka decompensation. For example, in the central nervous system, mild hypothermia results in impaired judgment and memory, but can progress to ataxia, slurred speech, and even coma. It also affects the respiratory system by initially increasing the respiratory rate, resulting in a respiratory alkalosis, but eventually leading to hypoventilation and respiratory acidosis, and even in the worst cases, respiratory arrest. In the cardiovascular system, you initially get a tachycardia, an increase in blood pressure, and a cardiac output, but as hypothermia progresses, it can lead to bradycardia, a fall in cardiac output, and eventually result in cardiac arrest due to asystole or ventricular fibrillation. In the kidneys, there is an initial increase in diuresis, but as hypothermia progresses, the renal function also deteriorates and results in kidney failure. Lastly, in the coagulation system, as is commonly known, the patient can develop a coagulopathy due to impaired platelet function and the impaired function of coagulation factors, but in severe hypothermia, they may develop a hypercoagulable state similar to DIC. I've separated out the perioperative specific changes that occur here. Remember that perioperatively, there are specific implications that we as anaesthetists have to consider. These include the increased risk of surgical site infection due to the impaired immune system activity at lower temperature levels. If the patient is shivering, this increases their oxygen requirement. If you refer back to your physiology of the oxygen hemoglobin dissociation curve, you remember that there is a leftward shift, and this means that the HB will be reluctant to let go of the oxygen at the tissues. Combine this with the shivering, and this will lead to an imbalance of oxygen supply and demand. This can increase the risk of intraoperative cardiac events such as myocardial infarction and arrhythmias. Finally, the pharmacology of drugs is also affected. There is reduced hepatic metabolism, and therefore the duration of action of many drugs are prolonged, including propofol, opioids, and muscle relaxants. The changes to the central nervous system also reduce the MAC requirement. I'll mention a few investigations briefly, as hypothermia is mainly a clinical diagnosis. The key thing to remember is when assessing a patient with hypothermia, the main thing is to rule out secondary hypothermia first, because if you don't treat the underlying cause, the rewarming strategies will be ultimately ineffectual. The most well-known change to a bedside investigation includes the development of Osborne J waves on the ECG. This is the upward deflection on the last part of the S wave where the QRS and the SD segments meet. Here is an example I've drawn. The main change you get to blood tests is that you get an increase in the hematocrit value, indicating dehydration due to the increased diuresis. You may also notice the increased viscosity of the blood when taking the sample too. Now for a controversial point. Whether or not you correct for the temperature when you take an ABG is controversial. Essentially, the debate has two sides, those that follow the alpha stat and those that follow the pH stat techniques of interpretation. When the ABG sample goes through the machine, it spits out two sets of numbers, one for the sample at 37 degrees Celsius and one which is corrected to the patient's temperature using a mathematical formula. I'm not going to go into the pros and cons of each side, but briefly, the alpha staters say that the reading at 37 degrees Celsius should be used no matter how cold the patient is, and the pH staters say that all samples should be interpreted at the patient's corrected temperature. Suffice to say that most UK guidelines recommend using the alpha stat method, i.e. you ignore the patient's actual temperature, use the numbers from the ABG that are at 37 degrees Celsius, and then treat the patient as if they are 37 degrees Celsius. You could argue that from the three components of the triad of death in trauma, which are hypothermia, acidosis, and coagulopathy, hypothermia is the most important as it can worsen the other two. It's also one of the reversible causes of cardiac arrest, so it's important to get the management right. Most patients with hypothermia have been cold for a while, so it's important that you don't warm them faster than 0.5 or 1 degree Celsius per hour. Rapid rewarming can cause a phenomenon known as afterdrop. This is when the blood vessels dilate and the cold acidic blood from the extremities rushes back into the central circulation and can lead to fatal arrhythmias. Outdoor swimmers are especially aware of this. You can broadly divide the management strategies into two types. These include passive and active methods. Active methods can be further divided into non-invasive and invasive. Passive methods include drying the patient and removing any wet clothing. You can also transport the patient into a warmer environment and wrap them in blankets and a hat. Here, an aluminium foil blanket, like a mylar type material, can be extremely useful. A bonus tip is to cut a section of the foil blanket and turn it into a hat, which you can use to form an extra layer on the head. The aluminium reflects body heat and therefore creates a much better insulating layer. Active non-invasive methods include using forced air warmers and chemical heat pads. If you have the kit, you can also place the patient on a heated mattress. Active invasive methods of rewarming include infusing warm IV fluids at 42 degrees Celsius, using a HME filter to humidify and warm inspired gases, and bladder, gastric, peritoneal and pleural cavity lavage with warm fluids. The most invasive methods include renal replacement therapy, cardiopulmonary bypass, or ECMO. but this is reserved for the most severe cases. There aren't any specific criteria for ECMO, so it's usually under discretion of the local centre in your region. In part 1 of this video, I mentioned you can do a quick checklist exercise to see if you've addressed all the mechanisms of heat loss. Let's do that here. The 5 mechanisms of heat loss are radiation, convection, evaporation, conduction, and respiration. Radiation and convection are addressed by wrapping the patient in blankets and a hat and using forced air warmers. Evaporation is addressed by drying the patient and removing any wet clothes. We can address respiration by warming and humidifying inspired gases. And finally, using a heated mattress directly counters the conductive heat loss. By quickly running through this list, you can be sure you've implemented a comprehensive rewarming strategy. Lastly, let's quickly review what are the changes to management if a patient with hypothermia undergoes cardiac arrest. I've linked the guideline in the video description below. As a brief summary, there are 3 main points. The key temperature to remember is 30 degrees Celsius. If the temperature is below 30 degrees Celsius and VF persists after 3 shocks, don't give any further shocks until the patient's temperature is above 30 degrees Celsius. The other point is, if the patient's temperature is below this, withhold adrenaline until they've been rewarmed. If your patient is between 30 and 34 degrees Celsius, then increase the interval levels of administration of adrenaline to every 6 to 10 minutes instead of the usual 3 to 5 minutes. This is again because the metabolism of adrenaline is slowed down in hypothermia, and therefore you risk accumulation and toxicity if you give it at the normal interval levels. And there you go. We've covered everything you need to know for hypothermia and temperature monitoring for both the primary and the final FRCA. We've covered the physiology of thermoregulation and the pathophysiology of hypothermia, as well as several rewarming strategies in this video. Remember that temperature affects almost every system in the body and has certain anaesthetic implications too, and so this would be a very good question for the examiners to write for both parts of the FRCA. For these clinical videos, I'll link the references in the video description below if you want to do any further reading. I hope you found the video useful, and thank you very much for watching.